Hello, and welcome to the Clinical Care Options Podcast. I'm your host, Sarah Anderson. In this episode, we will be hearing about optimizing care of PBC pruritus in the clinic setting. For this episode, I'm joined by Dr. Stuart Gordon from Wayne State University and Henry Ford Health System, Dr. Marlyn Mayo from the University of Texas Southwestern, and Brenda Remo, a person living with PBC. For more information about this program and to follow along with the slides, please visit the links in the show notes for this episode. And to get access to all of our new podcast episodes, subscribe to the CCO podcast channels on Apple Podcasts, Google Podcasts, or Spotify. Now, let's get started and hear from Dr. Mayo about addressing PBC pruritus with patients.
Talk a little bit about how healthcare providers deal with this in the clinic. There are recommendations from our professional societies about specifically addressing the symptoms in PBC. The AASLD says that the symptoms significantly impair quality of life, do not improve with our treatments, which are UDCA and OCA, ursodeoxycholic acid or obeticholic acid, and therefore they warrant separate evaluation and treatment. And then the European Society guidelines say that all patients should be evaluated for the presence of symptoms, particularly pruritus, SICA, and fatigue. So both societies make this point that the symptoms and the fatigue need to be specifically addressed by providers. Unfortunately, that advice is not always followed. So these are data from the real world about how often that is done. This was a study from the UK looking at providers' assessment of symptoms in PBC. Pruritus was assessed during the past 24 months in approximately 60% of patients, and it really should be 100%. Fatigue assessment, likewise, was around the same level. And so it is not uncommon for providers just to not even ask about these symptoms. Here's another study from the Target PBC trial, which was a real-world evidence study from centers across the United States. Patients were given the opportunity to complete, if they wanted to, one of several sets of patient-reported outcomes, which are surveys about your symptoms. The itching ones that were administered were two surveys called the 5D itch score and the PBC 40 itch score. And what you can see in the table here is the degree of concordance between what the patient was saying on the form versus what the provider was saying in the medical record. The patient had very severe itch. There was 100% agreement. The provider recognized it if the itching was very severe and also made a note in the chart. But if you have even sometimes severe itch or particularly mild itch or moderate itch, there was not very good agreement between what the patient was reporting and what the doctor was appreciating. And not surprisingly, it's the healthcare provider that consistently underestimated the patient's symptoms and the severity of those symptoms. And when you get down to mild itch, it was almost a flip of a coin as to whether the provider was going to recognize this. Now, there are various objective ways to score pruritus. I mentioned the 5D score, the PBC 40 score. These are fairly labor intensive. I mean, the 5D is 5 questions. The PBC 40 is 40 questions. So these are difficult for busy clinicians to do in the office. But there are also some very short methods of quantifying itch in patients. There's the visual analog scale, where patients mark a line anywhere on the scale from 0 to 10 that aligns with the severity of itching. Sometimes it's just a straight line. Sometimes it has anchor points or happy, unhappy faces, such as the example you see on the slide here. Or there's also a numeric rating scale where you just ask patients to rate from 0 to 10 what was the itching that you've had, the worst itching you've had in the last day. And that's a really rapid way to assess itching in the clinic. And anything 5 or greater is considered severe itching. We talked a little bit about the 5D itch scale and the PBC 40. These are frequently used in clinical trials, but they're difficult to use in the clinic. I do know some providers who are embracing these now within the electronic medical records realm, where patients complete surveys and questions online before they come into the office. And so they can complete some of these more extensive evaluations before the office. And they tell me that that's very helpful. So generally, what we recommend is a bare minimum is that healthcare providers should ask at every visit, are you experiencing itching? Because that may change. They may not have had itching and then may have developed, or they may have had it and may have gotten better. If the patient answers yes, follow that up with, how's it affecting your quality of life? Because that's a huge determinant on whether the patient wants to pursue treatment or how you can counsel that patient. And then consider giving them like a 0 to 10 scale to mark. You can do this while they're waiting for their appointment, or you can just, it's an oral question, because that gives a baseline at least to assess how well the therapies are going.
Sorry, Marlyn, I didn't mean to jump the gun on that one.
That's okay. It's important. Some people have noted, particularly in the UK, that how patients verbally report their itching may be different than how they record it on a form. So sometimes it's helpful to have both of those pieces of information. Okay, now I want to invite our patient representative, Brenda, to tell us a little bit about what her experience has been in the clinic with respect to the things that we just talked about. The doctors that you've seen, do they ask about the itching? Do they ever have you write anything down? Do you feel like they pay attention, even if they do ask you?
Outside of a clinical study environment, I have never been asked to rate my itch on a scale of 1 to 10. My doctors pretty much just say, how are you feeling? And I say, I'm itch like crazy and I'm tired. And they pretty much just say, yeah, that's the symptoms. Unfortunately, we don't know what to do.
So they don't ask you specifically about itching, but you volunteer it, and then it kind of gets brushed over.
Yes, it's just part of liver disease. There's stuff that we can try, but nothing's very effective.
And how does that make you feel?
Dismissed, insignificant. To a point, I get it, but it's like, that doctor's going to forget about me 5 minutes after he walks out the door. My symptoms, I live with 24 hours a day, 7 days a week. I just feel like the personal care is gone. Like any doctor that I've seen doesn't really take a personal interest or, okay, let's get you better. I know you feel like this. Let's do this. Or it's just kind of like, yep, that's liver disease. Okay, we'll draw your blood. We'll see you in 6 months, the next assessment.
Right. Yeah. So what you're talking about is the humanity side of medicine, right? Regardless of whether it's a known disease symptom or we do or do not have medications, that will work for you. Just spending that time to validate your feelings and ask questions about it is therapeutic in and of itself to an extent. Yeah.
Right. Yeah. Instead of like dismissing us of, that's liver disease, just more personal effects make your patients feel heard and validated. Like, we really understand this and we know this is debilitating, and don't just brush it off as, that's liver disease.
Or just possibly just expressing their own frustration with an inability to prescribe something needed for that condition. You mentioned that you're taking cholestyramine, and maybe just sort of acknowledging their own inability to treat it effectively.
Yeah, sometimes just saying, I wish I had something better to give you, or I wish I could just make this go away for you.
Right, exactly. Exactly. That is exactly like back in the olden days. That's how, doctors were. They cared for their patient. There was one-on-one relationships. And I think that has gotten lost. And with patients with rare diseases, and there might not be a whole lot you can do for us, but you can definitely be more supportive to us and validate us more.
Now, you'd be a great mentor for medical students, but it's not just the medical students who need to hear this lesson. A lot of times people who've been in practice for 10, 20, even 30 years have forgotten a little bit of that.
Yeah, I think that goes a long way. Just making us feel heard and making us feel human and making us feel like we're not crazy. This is real. We're not losing our minds. Although I think part of us are losing our minds too, but it's real and it's hard. And we need more help is basically my message.
I can hear the frustration in your voice. One of the things I find helpful in the office is asking for examples. Like someone says they have a lot of itching and it's miserable. Instead of just saying, asking for examples of how has it made you miserable, And that really kind of when you hear a specific story, that kind of makes it seem more real to us, as physicians. All right. Well, let's move on to our next section. I think Stuart Gordon is going to lead us through some of the ways that we can work on managing. We've talked a lot about just validating the pruritus, but there are some therapeutic options out there. So tell us a little bit about that.
Well, we'll talk about that. Thanks. And thank you very much, Brenda. That was just so moving. And it leads right into the commitment to finding pruritus treatment to provide relief, to set appropriate patient expectations, and really to have that realistic dialogue, and hopefully to create an individualized plan that incorporates the patient preferences, modifying based on response and tolerability, et cetera, and to consider clinical trials that are ongoing just for this purpose. There are some non-pharmacologic treatments that we all talk about, and it's always worth mentioning light bedding, cotton clothing. We can talk about topical moisturizers, cool showers, fragrance-free soaps and detergents, et cetera, and avoidance of irritating factors and fabrics. We try to identify anything that might potentially help clothing-wise, environment-wise. You mentioned some of the heat in Arizona, for example.
Yeah.
But there's some drugs, and we should probably talk about the drugs and the non-drug management. The AASLD guidelines specifically mentioned that we should start off with the bile acid resin. And this is what I think we've all been doing for many years. And Brenda very nicely explained how really awful this stuff is. It has to be taken very specifically in relationship to meals and in relationship to other medications. It's not pleasant tasting. It has GI toxicity. And so this is something that we've been living with as our first line therapy for many years. But I think all of us as clinicians know that this is sort of suboptimal. The second line is for the AASLD. Rifampin, which is actually an old TB medication, inhibits uptake of bile acids. The CNS factors are also considered in terms of the opioid antagonist naltrexone. And Dr. Mayo, with us here today, wrote the paper on sertraline, an SSRI that may also be helpful as a second-line therapy. There are a myriad of other options here, and this list goes on and on and on. We can talk about gabapentin, phenobarbital, plasmapheresis, the MARS system, nasal-biliary drainage, UV light, topical therapy. There are others that I can think of. I think they used to have a combination of H1 and H2 blockers. Flagyl was talked about at one time. They even mentioned corticosteroids, which may actually help the pruritus, but not good for the bone. So we don't use steroids. Anabolic steroids were talked about at one time. And of course, liver transplant, once upon a time, it could be thought of, but now it doesn't get you any MELD points and is really not going to move you up on the transplant list. And there are emerging therapies, maralixabat, odevixibat. These are approved for Alagille syndrome and the PFIC syndromes. And then there are other along the PPAR agonist category, including bezafibrate, elafibranor, and seladelpar. So we do have some emerging therapies that are coming there, and there are certainly also availability through clinical trials of linerixibat, volixibat. So there's promise, and I think that this is sort of the key message of this slide, is that there's a lot of old therapies and voodoo type therapies that a lot of us have fallen back on over the years, but there's sort of a light at the end of the tunnel. But I do want to mention here that antihistamines are not recommended. And I think they're frequently used by many of us, but it's not recommended. So I think we want to conclude hearing about Brenda's experience and discuss some of these different treatment and PBC related itching outcomes. And Brenda, do you have any sort of concluding words for us?
Aside from my previous doctor who prescribed hydroxyzine.
Did it help you?
No, not at all. That didn't do a thing. They tried to increase the dose of doing it, and that didn't help either. So, and now I'm just with the cholestyramine.
Have you ever tried rifampin, just out of curiosity?
No. My hepatologist just recently increased the cholesterol to the 2 times a day. And I think at my next visit, I'm going to bring up to him the fibrate or something, because that medicine is just very hard for,
It's interesting because We have patients who come to us having gone online and found solutions and saying, here, I read about this. I've had a similar experience treating patients with cholestyramine. It has to be given just very specifically, and it's difficult to tolerate. I've had very few patients who, at the end of the day, are very happy with cholestyramine. I've had some success occasionally with rifampin, but of course, it's got a warning of its own for cholestasis, and we're always worried about it in our cirrhotic patients. I have not personally tried a lot of the others. Marlyn, you've worked with sertraline. Tell us about your experience.
Sure. I've tried all of those medications in various people, starting with the bile acid binding resins. I agree they're difficult to take and it's a very unpalatable preparation. There are bile acid binding resins that come in a caplet form rather than a powder, but they're large and you have to take a lot of, so it's a lot of horse pills. But some patients would prefer that over the beach sand, but it still has the same problems with having to space it from your other medications. And I have seen problems with those resins interfering with the ursodiol absorption that they need to treat the disease itself. And so that's problematic. I have used rifampin, and I have certainly seen the potential hepatotoxicity that it can cause and rise in transaminases to the several hundred range. In my experience, I've always caught it early because I watch carefully for that. And so it's been reversible. But I believe the FDA warning says it can actually cause your liver to fail if you don't catch that early. But it is helpful. It does work. Sertraline is a SSRI, which we had done really just a pilot study comparing to placebo and found that it reduced itching. Most of these drugs, and as well as the naltrexone, which is an anti-opioid, most of them reduce itching about maybe 20%. We're still waiting for that magic bullet that abolishes the itching. And so, I think earlier Stuart talked about setting expectations when you're talking with the patient. And I think that's important that they realize there are a lot of options out there. None of them are silver bullets. They all help a little in some patients. They all have some side effects. We talked about the palatability of the bile acid binding resins, the potential hepatotoxicity of rifampin. Sertraline also has the potential for hepatotoxicity, can cause diarrhea. A lot of patients don't want to be on an antidepressant because they're afraid it will label them as having some kind of mental health disorder. And then the anti-opioid drugs like naltrexone can cause opioid withdrawal type symptoms such as tachycardia and sweating and hypertension and not feeling good at all, nausea. So they all have some kind of side effect. And so discussing all the pros and cons and setting expectations for how much the medications will benefit you, I think is important to do in the beginning when you're having those conversations, which should be occurring regularly and should at least last a few minutes, not just to dismiss them. Do you itch? Okay, that's what I expect. Let's move on.
Exactly. I think I heard a presentation once where you should at least listen to the first 90 seconds of a patient's visit before you move on. And I think this is sort of the message here. We should be listening to what they have to say and be setting realistic expectations. And I think it's important that we discern between the treatment of the PBC and the related pruritus. I have this discussion with our research coordinators who go through the list of trials, and they'll say, well, here's our PBC trials, because we're doing some of these clinical trials, and they'll say it's a PBC trial. And I'll say, no, it's not a PBC trial. This is a PBC pruritus trial. So I think it's important that we emphasize that our current treatment for PBC is not the treatment for the PBC pruritus. And that's sort of the major take-home that we're learning here today. There are patient resources, and some of these I was not really aware of. I was aware of the PBCers, but there's also morethanpbc.com, livingwithpbc.com, mypbcteam.com, as well as the Liver Foundation. And there are also clinical trials that are available for our patients with severe pruritus, and you can find more information on clinicaltrials.gov. The take-home points that we've really heard so well described here today include that PBC-related pruritus is frequent and a bothersome consequence living with PBC, probably much more so than just bothersome, as we've heard here today. PBC pruritus should be assessed at every visit, and patients want to feel heard, right? We've heard this over and over again, and knowing that their itching is being addressed. Understanding that the AASLD guidelines provide recommendations for first and next line treatment of the PBC-related pruritus. And if a treatment isn't working, a next line option should be explored. Unfortunately, new options are around the corner. Thanks to Marlyn, and thanks to Brenda, and thanks you all for listening to us today.
It's been a pleasure. Thank you.
Thank you.
Thank you very much to our panel of experts, and thank you to our listeners for joining in. As a reminder, to view the full program, More Than Just an Itch, the patient impact of cholestatic pruritus in PBC on the Clinical Care Options website, click on the links in the show notes for this episode. And to access all of our new podcast episodes, subscribe to the CCO podcast channels on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.